get your surfboard. And as you know, I have nothing to disclose, no conflicts of interest here. This is purely evidence-based. We've received some support from CAMH, and this is intended to be evidence-based. It's objective, it is not biased, and this is intended to arm all of us with the information that we need to make decisions in the aftermath of wave 4. And so we're going to describe the epidemiology along with the epidemiology of the vaccine. We're going to review the impacts that the pandemic has had on our population and outline some strategies to manage the evolving landscapes in our clinical practice. So the purpose of having a guided meditation around gratitude is we just partook in Thanksgiving. So we had a long weekend, and I know that a lot of us are sitting here and waiting for a possible tsunami. And even if you put on the news website, CBC, CTV, you read the newspapers, there's a lot of uncertainty about what the next 2 weeks are going to look like as we await for the outcome of Thanksgiving gatherings. And we've been there before. We've been there with many holidays over the course of waves 1, 2, and 3, all of the periods in between. We have much more data at our disposal now. We have a population that for the most part is vaccinated, and that's a great thing. But we still have in Ontario well over 1 million unvaccinated people. And there definitely are concerns about that transmission. And we also know that the Delta variant is transmissible in vaccinated individuals. So are we going to be seeing a tsunami force of cases in the next few weeks? Who knows? Our predictions in early September, if you look at the Ontario Science Table, were very concerning. The cases we're looking at being close to 15,000 a day in October if vaccinations didn't increase. And so there was a lot of concern and apprehension earlier in the fall that our wave 4 would be the worst one. And certainly the modeling set forth by the epidemiologists at the Ontario Science Table predicted some of the worst incidents of the virus and hospitalizations of the prior 3 waves. But if you look at how the situation has been throughout the provinces, we've seen different issues throughout the country. And we all know about the Open for Summer plan and how well that went in Alberta. We also know about some of the issues in the maritime provinces right now. So what we're seeing is we're learning the outcome of various restrictions and measurements that the government has put in place and how they've worked or not worked in different areas throughout the country and throughout the world. We have a wonderful tool that I would encourage you all to use, which is the COVID-19 tracker.ca. This is updated in real time. It's supported by the Government of Canada, and it provides a wonderful rolling average for the number of cases, the percentage of positive cases, and also other pieces of information, including hospitalizations and ICU stays. This is a very good and reliable source for you to get some information about what the situation is like on a daily basis, and it's updated twice a day. From that, you can see that effective Thursday, which is when I submitted these slides, we have seen since the onset of COVID-19, close to 1.7 million cases, close to 30,000 deaths, and over the course of the past year, roughly 8 to 12 months, we've administered 57.3 million doses, but we still have 10 million doses in our surplus that are just waiting to be used. And grateful to see people like Javed who are at vaccination clinics utilizing those doses, which are government ordered with the expectation to vaccinate all Canadians. And so some of the numbers there show that plateau that we're at, whereby 87.5% of eligible Canadians have 1 shot, and 82% of Canadians have both. And you might say 87.5%, that's a pretty good number. We have a lot of Canadians who are vaccinated. Well, it's good, but when you look at the total population, we still have millions of people who are unvaccinated. And if you have those people in certain areas, as we're seeing in northern British Columbia, where there's low rates of vaccination, it's a veritable hotspot for the virus to spread and to make hospitals and ICU environments meet their capacity. We're also learning over the course of the past while about what the impact is of vaccination on our hospitalization and hospital resources. And when you look at the top graph there, which are people in hospital but not in the ICU, you can see that out of roughly 150 people, 100 are unvaccinated and 11 are partially vaccinated. In the intensive care unit, you can see there that out of about 90 patients, 68 patients in the ICU environments are unvaccinated. And that's the trend that we see across all provinces. That's the trend that we're seeing throughout the country and other parts of North America and Europe. And by and large, those consuming in-hospital resources are unvaccinated or partially vaccinated. So there's a significant strain and impact on our system with respect to the unvaccinated population. Now, we've all learned how to live differently. And these are some photos that I'm going to take you through that come from different parts of the world. And this is overseas in Europe, where these circles of social distancing have become the norm. And I think we've all gotten used to, making sure you have a mask in your pocket before you go into a store or restaurant. Everybody has either laminated or put their vaccine passport as their screensaver on their phones. When you see these spots for social distancing, we don't even think twice about it. People have become aware of how masks can help, the importance of washing hands at minimizing the spread of COVID. We have wonderful epidemiologists who have outlined the math behind social distancing, which clearly works. Social distancing and masking, these are the mitigations and efforts that have significantly dampened the impact of the waves and led to a reduction in case counts. This doesn't apply only to COVID-19, but it applies to all respiratory viruses. And for those of you who have children at home, the frequency of illness in the house has significantly dropped in the past 2 years. As a father of 3 kids, I was used to someone being sick all of the time, when in fact, I think our 2-year-old, I think he's had 1 cold in 2 years. So obviously these measures stop COVID-19, but they stop everything else from happening. But we've also created this new way of living that is quite different from the old way of living, which is we don't get sick anymore. We have the science table. This is a very busy slide, but the science table has an outstanding resource, and this guides in-hospital and outpatient decision-making around COVID-19. Who gets these treatments? Dexamethasone, who gets an antiviral? Who gets an interleukin antagonist, tocilizumab? And who gets monoclonal antibodies? So when you think about Trump, when he was sick with COVID, he got monoclonal antibodies, right? He wasn't vaccinated and he got these. Well, these are now available in Canada. At the UHN, we were just able to procure a supply, and this is indicated for people with moderate illness who are hospitalized. In the unvaccinated population, it's actually worthwhile giving in the mild illness phase. So we now have treatments at our disposal, and we have a wonderful scientific group that can guide our decision-making and provide some clinical practice guidelines to treat patients with active disease. But when we start thinking about the future, and we start looking at the downstream impact, people are thinking about the changes to the healthcare system. People are talking about long haulers or long COVID syndrome. But what about the other indirect causes by this virus? We shut down a lot of stores, a lot of businesses, a lot of restaurants, and we had to supplement people by virtue of emergency benefits. And so on this slide here, you can see that in the 6 months after the pandemic was declared, our country spent close to $100 billion replacing wages, subsidizing payment. We had moratoriums on rent increases. So there is a huge economic cost to our country and our province mitigating the impact of the virus. There's other unintended or indirect consequences. And for those of you who work in the addictions field, or for those of you who have been picking up the newspaper on weekends, a ton of editorials out there about the increase and the silent epidemic with respect to opioid overdoses. And you can see on this chart here that in 2020, if you look at the 3rd and 4th quarter and the predicted outcomes, and at the bottom it talks about different health interventions, of which we frankly have had none, you're looking at close to a 60 to 80% increase in opioid-related deaths since the pandemic has declared. When you look at some of the habits and changes, as part of our Echo Coping with COVID, our partnership with CAMH, we've learned a lot about the significant impact on people's mental health from a population standpoint of the pandemic. We've looked at the increase in weight and the associations with obesity. When you look at the obese population and you look at some of the habits and changes, you identify that in this population, there's an increase in substance use. There's an increase in food stockpiling. There's an increase in anxiety around eating habits and an increase in insomnia. And this downward trend with respect to overall mental health of our population has been seen across all populations, not just those who struggle with obesity and weight management. We're looking at trends outside of simply physical health. But when we talk about the Great Resignation, working from home, it's not bad. Who wants to get in a car and commute, especially now with those issues around traffic? Which people were always toying with the idea of moving out of the city and moving to a different area, trying on new shoes, quitting the food service industry and working elsewhere? When you look across the global workforce, we're seeing a trend known as the Great Resignation, which is people are completely changing their employment habits. If you look at the food service industry, how many restaurants have you seen shut down for lunch service or open only on Friday and Saturdays by virtue of being unable to have enough staff to work there? So a lot of change has happened and a lot of change is predicted. Not only did change happen as a virtue of the pandemic, but some of those changes may be permanent and some of those changes may be coming back to a set point. All of us physicians received a letter earlier this week from the College of Physicians and Surgeons of Ontario, and this has also been supported by the public health officers of the province and of the country. When the pandemic happened, there was a shift to virtual care. We don't want patients coming to our waiting room, spreading the virus. We don't want us as healthcare workers to pick up this virus. It's now October 2021, and we have an effective vaccination. It's time to start seeing people in person. You can't catch everything in a virtual visit, and our patients need to see us in person. So this is a letter from the president of the College of Physicians and Surgeons of Ontario that went out to all Ontario physicians this week, encouraging them to get back into the office. For sure, some things are best done over the virtual environment, but your well baby visit and pediatric screening, maybe it's time to do that in person. Everyone knows about the trauma that our system has experienced, frontline healthcare providers, the nursing crisis, the outflux of nurses towards early retirement and pension, the number of allied healthcare staff on emergency leave, on disability leave, on leave of absence for other reasons. This has been a traumatic experience for everyone in the healthcare environment. Look at the collective feeling that we had just at my hospital a few weeks ago when we had to walk past anti-mask protesters just to come inside and do our job and provide care for the ill. There's a significant amount of attrition in many of the professions within the hospital walls, and there's a significant amount of emotional burnout, moral distress, and post-traumatic stress. We talked about the emergency standard of care in Ontario, and this is deciding who gets to go into the ICU. If you're likely not to benefit, you go to the ward to receive palliative care. Alberta's pretty close to enacting this right now. Other downstream impacts. Inflation. Inflation is increasing at a pace above our traditional rate of rise of inflation. This is coupled with the rise in food prices. This is coupled with a rise in energy prices and natural gas. We've all been told to brace for an increase in 30% simply to heat our houses and heat our apartments. So I wonder at this point in time, with each subsequent wave, now that we've created vaccines, medical treatments for the active management, the lethality of the virus is going down with each subsequent wave. But it appears to be that the inequality is increasing with each subsequent wave by virtue of these direct impacts of the virus, the lack of access to traditional healthcare resources, whether it's in-person visits or whether it's simple hospital resources for things like screening colonoscopies, in-person assessments, and then all of the downstream impacts from the economic impact, the changes in our food prices, our energy prices. We've traded off lethality of a virus for inequality of our population. And so knowing this, I feel that it's important for all of us as care providers to start seeking for ways by which we can make a difference and we can utilize this information. So I wanted to take a pause and remind all of you here today to use these wonderful resources and databases online to arm yourself with good, evidence-based, scientifically guided information to help you adapt and adopt to a new way of practicing to serve our patients. And I provide 8 specific examples that I'd like us all to take to heart. And these 8 examples will guide our discussion at the end of this presentation. And so we can see acute management, right? There's been a lot of debate about what's the best way to manage COVID-19. Let's stay at home and lock yourself in a room and drink soup. Well, we're now starting to recognize that it's very rare for COVID-19 to present concomitantly with a bacterial infection. So don't give antibiotics, steroids, monoclonal antibodies, antivirals. Depending on the severity of illness, and all of the home monitoring programs and hospital settings are prepared for this, there are treatments that can help. Long COVID awareness, get ready for this. We're starting to see a lot of public mobilization. There are about 3 patient-driven online groups and online communities about creating awareness of long COVID. There's huge Facebook groups about whether or not there's some neuroinflammation. The spike protein crosses the blood-brain barrier, and perhaps this leads to neuroinflammation, which gives the brain fog. But we're also having a difficult time teasing out whether or not this is a direct and downstream impact of the virus or something else entirely. But regardless, we're definitely going to have a spotlight and awareness placed on these quote unquote psychosomatic illnesses, chronic fatigue, chronic Lyme, fibromyalgia. And so we should expect to see patients meeting these criteria showing up in your practice. And there's some wonderful resources online on the Government of Canada website to guide decision-making there. Get ready for the mother of all flu seasons. Over the past few years, flu vaccination rates have decreased and the flu has been relatively dormant. So we're not sure which strain we're going to see this year. We also know that our population is not as vaccinated against the flu as possible. But why not capitalize and take advantage of the knowledge and information around vaccinations with COVID-19 to get your population vaccinated? And historically, those under age 50 have very low flu vaccination rates. Capitalize on them. If we can decrease the incidence of seasonal influenza, we're going to further decrease the negative impact on our hospital system. For those who are still vaccine hesitant, share the data, focus on the facts, and look under the hood. Try to understand what motivates somebody to be resistant to vaccination at this point in the game. Did they have a bad negative experience? Did a friend or family member have a bad negative experience down the line? Either way, continue those conversations, continue to support people, and point them in the right direction. Poverty screening. This inequity that I've talked about is one that will likely lead to changes in terms of wealth disparity in our population. The Canadian Family Practice Council has created a wonderful poverty screening tool that asks some simple questions like, do you have help preparing your tax returns and have you filed your tax returns? And some other pieces of information that allow you to identify people that may be in need of financial assistance. A lot of change happening in the clinical walls. We have human resource models whereby nurses are training personal support workers to work in the ICU environments as a buddy system. It's very different now in the hospital walls. A lot of turnover, a lot of new people, a lot of inexperienced people. Rather than being dismissive, put your best foot forward, role model with them, support them, and help them to do a good job for their patients. See people in person. This can be done safely now. We have vaccines that are effective. We understand the values of social distancing, of masking, of hand hygiene. Think about those vulnerable populations that benefit from in-person assessments and bring them back into your office. And finally, as a parent, put kids first. Children have had 2 years of school disruption by virtue of the pandemic, and everybody is anxious that at some point after Halloween or in the winter, we may experience another one. So children have lost access to screening for things like learning disabilities and abuse. So if you have an opportunity to see children or families in your practice, please do so in person and make sure to screen them for things that may have been missed, and always advocate for them, because this is the one part of our population that lacks advocacy themselves. Here are the references that I talked about. I encourage you all to look at these websites, especially COVID Tracker and the Science Table for current and updated guidelines, current information. The CFPC has the poverty screening tool, along with some other wonderful tools that you can use in primary practice. And the Canada.ca website has a lot of information on long COVID, the economic impacts, and the evolution of evidence-based treatments for this disease. So thank you so much for your attention today. I apologize for some of the technical difficulties, but I'd like to step back now and allow Sanjeev to facilitate some conversation about the topics that I brought up today.